Hi, and welcome to the PHC research webinar in Joburg. Thank you all for joining us. My name is Jhb Musa. I'm a family physician in Johannesburg Health District and the chair of the District Research Committee in the District Health District. We're very fortunate in having at our webinar, the first webinar, we have Prof. Yusuf Musa who will talk through to us about how reviewers work. I will share a little bit at the beginning about who is in the committee, how we've actually formed, what it is. It's more or less what is going on in the in the website, so you'll be able to pick up on all that information. We're also going to go through today through 3 presentations, helping to share with you what kind of work has been done in Johannesburg. So Andy Kim, who's joined us, will be talking about mental health in COVID. Simon Shabangu will be talking about malnutrition in children, and Sinead will talk about the possibilities of MMR vaccine for COVID prevention. So we'll come back to that short later. Let me start by saying thank you all. We're really grateful for the 40-odd people that have joined us. We've had twice that number registering, and we hope that more will join us as we proceed. I think it's up to 55. Thank you. So this webinar is basically the first of many that we plan, and is essentially to try and share the work that is happening within Johannesburg. I think the challenge has been, and I'm going to use the website which we're using temporarily to take you around rather than a presentation. So basically, as a committee, we are challenged with trying to deal with this. This is our functions, our terms of reference in the district, and that is to coordinate and manage research processes within the district. I think this is something overall. I think in specific, we have been tasked to deal with reviewing research proposals, and that often occupies a lot of the time of the committee, and it has occupied a lot of the time previously. And when I was in the committee previously, I found that we really did very little else than just chase our tails with research proposals, and that were taking far too long because of simple administrative challenges. So I'll go through briefly how we are trying to sort of streamline the process so that it is easy for you to make sure you understand how to go about it if you want to do research. So I'll talk a little bit about that, and then Prof. Yusuf Musa will talk a little bit about what happens behind the scenes once you've submitted it and it's gone into the process. You know, what are the reviewers looking for, and to help you reduce the likelihood of delays. So I'm going to talk a little bit about, Prof. Yusuf will talk about that. So the third thing that we are there to do is to help make sure that people use the Nhrd. The Nhrd is the National Health Research database, and it is supposed to be not just a sort of painful step you have to use and this very impenetrable platform. So we do have challenges with it ourselves as a committee. We hope that at our next meeting, we'll be able to share with you what is the, what are some of the challenges that even we struggle with at a national and provincial level. So the next webinar will actually try to get that kind of feedback from people at that level. The fourth thing that we are doing is trying to mobilize resources for research. And I think that that is something that we will still have to think about. We've sent out a questionnaire, and there have been a number of people who offered all sorts of supports. We've put out there, would you be able to be part of the webinar, share your research? We even asked about training proposals, and I think we need to just look and think broadly. So we hope to engage with you as well for more ideas as to how we can take that forward. But we think that some of the key things we need to do is to have a conversation more about how we synergize around resources. So, for example, the next webinar in November will look at talking to Prof. Shabir Mahdi, besides sharing the work in his research unit, to look at WITS and the collaboration between WITS and the Johannesburg Research Committee. So I think that we're going to look at that kind of thing. How do we plan together with big research organizations and otherwise? I think the last one is to promote the use of healthcare research outcomes. And that's really what we're trying to do today, is to make sure that what is being done in Johannesburg, especially, is not lost. It's brought to bear on what is going on in the district. We are often challenged by whether this webinar is as accessible to our workers and managers on the ground. So we're going to be busy looking at those kinds of things as we're going along. But as a begin, those of you who are here, this is the beginnings of sharing what you've done, what great researchers have done, and that they can add value to the health system. So those are basically, what we are have as terms of reference. I just want to highlight the members of the committee. I am the chair. I've just been appointed about a month or 6 weeks ago. Dr. Jimmy Aki is the family physician for Johannesburg. He's responsible for the doctors in Johannesburg. Prof. Yusuf Musa is also in Johannesburg as the lead psychiatrist there. Dr. Baske Deskai is a public health specialist, but he's acting as the current health director in Johannesburg and looking after the entire city of Johannesburg clinics. Dr. Maggie Petkova is a family physician based in Discoveries. Mr. Joe Shikpambane is an environmental health practitioner who's very active in the committee, working in the city of Johannesburg. Ms. Bertha Malarekoa is an AD in this province side in the district. Mr. Beki Sibeko is a very senior manager in the COJ. Mr. Dominic Mashvangu, I think, is there as an administrator, but I think he may return. We've also got 3 or 4 other new committee members who I should just mention. Dr. Michelle Tuluta is a family physician who's just joined us. There's Ms. Dr. Joel Francis, who's from BITS Family Medicine, who's also joined us. And there's Dr. Atia Mosam, who's a public health practitioner, also did some work previously in the district, and she's joined us. And then there is a 4th person who will be joining us. She's Sikosana as well, Bongi Sikosana, who's basically going to join us next month. So we've tried to beef up the members of the committee to make sure some of the people in the committee are actually struggling to participate, and we hope we can strengthen the committee so that all these different terms of reference can actually be acted on. The secretary is Ms. Busi Sikosana. I'm sure that all of you will get very familiar with her. These are her details, her landline, email. She's the secretary. She's been working frantically, and I've been trying to sit with her to make sure that a lot of the sort of administrative challenges that she faces are dealt with and that we can speed up the whole process. And we're close to, in fact, catching up on a big backlog for the whole 6 months. By the end of next week, I think most of you should start getting letters for your applications by end of next week or the following week, and we would be hopefully up to date, in the sense of all applications. So apart from that, let me just go through very quickly the process. So if you want to do research in Joburg, I think please for now come to profmusa.com. Just Google it, you should find it quite easily. If you go to the Jhb DRC at the top there, and then apply to, you'll come to this page, and that is basically your begin point. What we advise you is that the way to go about applications is to first go and click on this and get into the Nhrd platform. And in the Nhrd platform, let me just log out. You basically would have to register. And once you register, you'll then get your Nhrd details. Please try and keep that on record, your login, because if you're going to log in, you need those details. Once you have now gotten that, please, my suggestion to you is that before you whoops, before you start with your applications, which is to sort of submit an application. Let me just go down there. Okay, let me just get out and try my login. Okay, once you start, and as a person who wants to now submit a proposal, you basically will be faced with a submit a new proposal. Please don't rush to do that. First start with getting a list of all your various researchers up onto this system and start with that. Once you've got your researchers, anybody that's associated with your research, then go to submit your new proposal. Because once you do that, you then have your choice of applications. We advise you, this is really only if you're doing research in the actual National Department of Health, which very few people will be doing. They'll be not doing it in that building in Pretoria, but they'll be doing it in various services across the country, and that's really the provinces. So you need to decide which provinces you're then going to go and do, and in doing that, you need to decide which district you actually start with. So let me just see, I think you'll come to that. You'll have to pick up who's the first person in there. You can then go to the title, the province, and key in that is you need to pick the province that you're interested in. But once you do that, you need to be able to search the facilities. Usually you go there. People tend to pick up Gauteng. You only pick up Gauteng, you only click that if you're doing things in the offices of the Gauteng Department of Health. Otherwise, don't bother putting that in. Again, the same thing there. If you're clicking the city of Johannesburg, you actually are picking the city offices itself. So in other words, staff and managers in the office. This is not a cover-all. You've got to, if you want to clinic, if you want to go and do work in all the clinics of Johannesburg, you've got to click all the different clinics you want, not that. So you actually do not want to do it in the province, nor in the city offices themselves. You want to do it in facilities. You've got to pick out all of those facilities. Now, unfortunately for us, they've lumped the other hospitals into the facility. Be very careful. If you are picking facilities and if you're picking Johannesburg, when you're picking Charlotte, it will not come to us. It goes straight to the Barra Hospital, Chris Hani Barra Hospital. So be very specific as to exactly which facility you want to include in your list of facilities. And this is the heart of the problem. We need to be very careful, and you need to be very careful as to which place you click. But that's the specificity, and we often get confusion when you're putting in this application. Other than that, I think the research activity, the sample framework, I think Prof. Yusuf will go through some of these things just now. Please make sure if you don't have your ethics approval, you may still proceed. It seems to allow that. I think just look for the option. If you don't have your ethics yet, we still prepared in Johannesburg to actually find your proposal and work on it whilst it's going through ethics. And we will then send you a provisional letter if we don't have ethics, and then you can get the ethics, and we can then give you a final approval, official approval, which is signed fully once you give us the ethics. But we cannot give you a signed permission until we have the formal ethics approval sorted out. Otherwise, the rest is fairly simple. This is, I think Prof. Yusuf will talk about this, the details, the support documents. Please add on everything that we need. Sometimes people forget simple things, so please include them. And I think if you submitted it and get an email, you can even use that for the research ethics approval that you've submitted it. That's good enough. If you are still doing it or you're doing it concurrently with us, then you review and you submit. Please look carefully through it. If you have something that's not quite right, please go back and fix it up before you submit it. So this is the process of submitting a an application. Once you submit it, we actually, and this is going to be done by Busi, she goes in onto the Nhrd platform and she checks on every day a new application. And she then downloads the information and circulates it amongst us. We then review it, give a feedback, and then once the feedback is obtained, we then manage this process where we then can either give you official approval, or if you haven't got the ethics, we would then send an email to you saying, listen, we've got a provisional approval, send us your ethics. Once you give us that, we will give you the formal official approval. So that can take literally a few days. And we hope that, in fact, in the district, we can manage an application within a week and give you a letter. One of our constraints is that once we decide, I decide, yes, we approved it with our process as a committee, at the moment, it has to go through to the managers. And if it is involving the city of Johannesburg and the province, it needs to go to both these senior managers, Mrs. Moriwane in the province, the district, as well as Dr. Baske Desai on the city side. So that can take literally a week or two because they've got to sign it. So we are busy negotiating with them to give me authority to sign on their behalf, and we can then try to work to 1 week. At the moment, it can take up to 3 weeks, and under the best of circumstances. So that's basically your application. There is this research manual. I would strongly advise you go look at it. It gives you all the details on how to work with the Nhrd and makes it simple to use. And what I've just told you now is all here. At any point that you are struggling with, getting through to Busi, there's all the details. Her numbers are there. And that's basically how we will function it in the district. I think we are trying to use this opportunity to share research. If you click on Joburg Research, you'll see anybody who's already given us reports or publications, and the people who, in fact, we've asked to present today, their articles are all there. But I want to, before we close, just quickly say, we really encourage all of the researchers out there, however many years ago you've done research, if you've done it in Johannesburg, we really would appreciate it if you can submit something to us. So we've done this, this setup here. You basically need to go in and set up an account. That account, basically, if you have not done this, is create an account. You then log in, and this will allow you to submit like an abstract to a conference. We would like it up to 1,000 word if it's a report. If it is an article, just simply provide us the abstract and attach the article. If you've got pictures, videos, anything that you think would make it nicer, more useful to present, please present it. We will then post it on the website. We'll go through a review process. We've actually had several people who we've agreed to include as reviewers for this process beyond the research committee. And I think that would allow us to get your research literally peer-reviewed and published in a sort of forum that's like a conference. So I hope you'll work with that. We would really appreciate it if you can share your research. At any time, if you feel you'd like to add your voice or support us, please feel free to go to the support. And as we're going along, the webinars will be posted up here, and you can then go from there. And I think with that, I think we are covered. I see some questions, and perhaps we can go through them very quickly, and then we'll move to Prof. Yusuf Musa to talk to us in detail about how you'd like to do or some of the details around the details that you need to worry about when you're doing it. So Evelyn basically asks, thank you for the compliment. Can you please also take us through the renewal process, as the recommendations are valid for an annual period? No problem. I think that, Evelyn, essentially you need to, generally when you have a renewal process, you go to the the research committee and you get the renewal from the ethics. Once you've got that ethics committee renewal, you just submit it to us. We will generally just send you a reply with our ethics signed by me, continuing the same for a year. So this should be very quick and easy. It's just a return letter, reply to you, and it can happen within a day or two. So feel free to just send us, but the ethics is what we require. Because usually the ethics will be our gatekeeper and we'd like that to happen. So I hope that's helped you to understand any renewals. Tabile Mumsomi asks, can we continue to select facilities in the hospital on one Nhrd? Yes, you can do that. What it does mean though, that it is two authorities that are gonna have to vet it. And if you've got three hospitals and 4 hospitals, you must understand, even two districts will mean it's 2 districts that are going to be. So you can put it all in one application, but you must understand that there are going to be many more different committees reviewing it, and that can delay you. I generally advise my registrars, please be careful when you try to do work across districts. It does take extra work, and you've got to follow up in the committees. You know, Joburg is trying to move it faster, but I can't promise of any of that for any other of the committees, you know, across Gauteng. So would we do 2? I think no, don't worry, just one, and you can cover the entire Gauteng sets. It's just the process that gets delayed because different authorities will look at it. So I hope, Tabile, that answers your question. Tabile, you ask, where are we sending the biannual progress reports? Tabile, we'd like to have them not every 2 years, we'd like them annually. We would really appreciate that because we want to see you, and it is not about, you know, it is about you sharing your progress. Even in non-progress is something we'd like to hear about. So send us your report and use that to send it. The, you know, the report should report to Johannesburg, Jhb DRC. If we can, in your presentation, sharing your challenges, the difficulties you're having is just as useful to us. Progress is great, but also non-progress is just as important. So where you're struggling, where you're having a, you know, even research issues, we will try to get people to support you. We will respond. If it's a sort of system problem, the health system giving you challenges, we would also like to see that that is addressed and know about it. So we are quite prepared to do that. I know that I've got somebody with their hand up. If your hands are still up, please keep it up if you want to speak. So please, apologies, I missed that. So Tabile, please, and anyone, please submit annual progress reports. It's a simple 250, 1,000 words is up to max, but it can be a short report, you know, and make it something that's useful for people to see what you've done or your research so far. So I hope that is handy. Yusuf, feel free to chime in if you want to add some of the answers to these questions. Some studies don't require annual renewal. How do we renew COJ in this case? Same process, just email Busi, telling us Busi handles both COJ and the province. So on both sides, feel free to call on us, so send an email to Busi, details are out there. And just tell her I've got my ethics renewal for the next year. I need a renewal for the service, and we will give it to you quite quickly. Seshlule Moyo asks, how much time does it take the committee to approve the process? Previously, it is taking very, very long, and it can be, you know, sometimes months. So we've had some proposals that we've been trying to deal with from February this year. So I apologize profusely for all the difficulties in the last few months. I think we are hoping to make it right down to 3 weeks at maximum, and we hope to work it to a week. But 3 weeks, I think, is a reasonable time to get. And if you do it concurrent to your ethics approval, I think that you submit it at the end of the month to us. We will give you a provisional letter support, so you can provide that to the ethics committee. You can then submit to the ethics committee. So then by the time you get your, you know, we'll give it to you probably before your ethics committee. and then it'll be provisional approval. And once you give us your ethics approval formally, we will then give you the official letter. So I think all of this can take 6 weeks and you'll be all sorted. Leisha asks, can you please share the process of the different types of research approval process? Thank you. I think there's slight differences, and I appreciate the comment. If it is, generally, if it is clinical research, even non-clinical research, any of these studies, and Leisha, if you start waiting for any study that's only Johannesburg, please email us to Busi. But if you're, as I've said to you, if you're having research that's being done in more than one entity, so consider the city of Johannesburg, the clinics and CHCs as one entity, even the hospitals which are South Rand, Beki Mlangeni and Edenvale Hospital, they will be all managed by this district research committee. But Charlotte Mateke, Barra, Chrisani Barra and Helen Joseph have their own committees. If it is in a district like Kuruleni, they have their own committee. So if your research happens to involve other entities, then it may be delayed. Generally, clinical trials, we do not approve it, we simply recommend it. It will then go through to the province. Province approves all clinical trials. Also, any final, any approvals by multi-entities, cross districts, it is not dealt with at province, but it is just at different entities. So just note that clinical trials do involve a provincial decision-making process, which can be a little detailed. I think that the question you're asking, Tabile, is SAPRA progress report sufficient? You know, if it is easily readable, we want it not to be heavy-handed research. I mean, the idea is to make it easy for our managers to read, for our, you know, other researchers to read. So if you think it's reasonable to read, submit it to us. If we feel, you know what, it needs to be improved, we'll send you some review comments and ask you please to do a different job. I'd say fine, give it a shot and let's see how it goes. But I don't think we want to make extra work for you. So let's give it a try. Tabile, I think the SAPRA report might be good enough. You could have an attachment and just simply have the abstract enough as the report and attach the report as the main. So please keep the limit to the thing down. Pictures and other things, really, it's a blog. It's not really, you know, it's going to be something that's more richer. So please try that. From our side, Evelyn says that Nhrd doesn't allow if you don't attach ethics approval. I think that's true, but what you can attach, and for us, I would say, is take the letter that you receive from ethics as the receipt of your acknowledgement of receipt of ethics, and just PDF it and attach it as the ethics approval. So we've seen, no, you've submitted to ethics. If not, just attach a document that just says, I will submit ethics concurrently, and we'll pick it up. I can't speak for other ethics committee, other committees, but in Joburg, we'll be okay with that. So even, you know, as long as it's a quick document, you know, any letter that just says, we would like to do a concurrent approval, we will manage the process. So don't fuss, just get it through the system and we'll take it from there. I think we kind of reaching the end of time on questions. I'll try to rush through the rest if Yusuf doesn't mind. I think, hi Prof, what if we want to do research on other government projects? Smart Lockers, PDU, CIPLA, they've all been donated. How does one get approval to conduct research? I think that, you know, even the you might say, partners, anyone who is doing work or working in the city, in the province or the city-owned facilities, you have to get the permission. So even all of this is possible because even the people who are managing Smart Lockers, PDUs, the CIPLA, etc., are doing it as agents of the Department of Health. They're doing within on behalf of. So these things need to go via us. It might require, I think what I would suggest is you get some sort of letter of support from those agents that they are happy with you doing the research. and attach it as a letter of support, I think that helps you, so that we know that you've had some discussion with them. I think since they have the option to select, no, I think that if you want to do something like that, if you're going to do smart lockers, PDUs, etc., sharp left, you should know which facilities they're in. So contact the agents and see which it is, and then select the facility where it is. And that would be fine enough, but you need to do some homework. We don't have that capacity. If you're struggling where you need data that is at a district level, so in other words, it's not you looking at data in the facility, you're looking at data within the district system, then you simply choose the Johannesburg Health District offices, because essentially data is a repository at that level. It's not in a facility, it's in the level. So if you want to speak to, tier.net data or DHIS data, that's where you need to ask for the approval. All right, and even HR data, etc. So think about what you're asking for, and that's really where that would be located. And generally, if you're going to do research, you ought to do some homework, to talk to managers, talk to people in the space about, where data is sitting exactly before you submit an application. And some people are just fishing, for some information somewhere, and it doesn't work. You've got to do some of your homework, and we will be very unhappy if you just seem completely blank about what is going on. That doesn't look like strong research. Quickly, if you have had any other at a later stage after, you'll have to do a repeat application. You can't do it once you've received approval. You'll have to apply for further approval. You can't really do that. You could try by submitting a letter to us in the district, if it's only us as a district. Submit a letter requesting additional facilities rather than going to Nhrd. I think that might be worth a try, and then we will decide as reviewers whether we would accommodate that or whether you want to go through a normal full application. But that might be what you expected elsewhere. Does Rahima Musa? Yes, they have their own committee. All the big hospitals do. Then is this webinar recorded? Sorry, I'm not even sure if I did record it. I think I did not. So no, it's recorded. So yes, you can get the recording. I'll post it up on the website, so it's there. What is the value of an extra form? One form, the declaration of intent. I'm not sure where this is. I think we're going to have to answer this later, Kafiso. I can't remember that form, but maybe Yusuf can answer that question. So let me move on. Thank you very much for all those questions. I hope they've been useful. And if there's nobody who's had their hand up, we're over to Yusuf. So thank you, Yusuf. I think you can start there. Prof. Yusuf Musa has been with the committee for many years now and has a better sense of all the sort of little itsy-bitsy stuff that tend to get turned away. He's a little more difficult than I am, but I think you'll understand his mindset. Having been through the process and seen the difficulties that we face as managers and senior clinicians in the district. So with that, over to Yusuf. Thanks, Yusuf.
Good afternoon, everyone. Thank you for, Jhb, thank you for the introduction and thank you for the opportunity. And welcome to everyone that is part of this webinar today. I hope to be brief, just coming back to some of the questions that Jhb was trying to respond to, Prof. Jhb Musa. Just to say that with regard to the form, I'm not familiar with that particular form annexure, but we will look into it and hopefully respond. As far as the other questions, there wasn't anything particularly that I wish to add, except to say that the process is pretty easy. My only question would be to Jhb Musa, and one of the questions which were raised, that if you do not have an ethics approval, it seems like you can't register with the Nhrd. And if you can't register with the Nhrd, then we in the Joburg will not pick it up. So I think we need to just look into that. How is it that the Nhrd can accept a application in process rather than the actual approval? But we need to look at that. let me come to what we're looking at. As Shabir has indicated and highlighted the roles of the responsibilities of the DRC, besides to review research proposals and to grant permission to conduct research in our facilities, to support the development and appropriate use of the Nhrd, and then more specifically, and which is the bulk of what we will be doing, but we would like to and we encourage to try and support and facilitate research activities in the district, and also to promote the use of the outcomes, to advise and communicate to researchers, research institutes, and policymakers. Now, with regard to the research proposal itself, our job is to consider the impact and the risk of the studies on the district health system. We're not here to look at the methodology of this thing and how you're doing your studies and advise on whether you're following the proper procedures. What is your, more in terms of what is your research question, what do you plan to do, and what impact would that have on the district health system? We try to provide advice, expert opinion based on our knowledge of the system, and we will look at your methodology to advise you whether this is feasible or not, and knowing the system better. But that's our prior thing before we approve a research. We're supporting the development and appropriate use. We mentioned that, and therefore no research can be considered until it is registered with the Nhrd. Their job is to coordinate research throughout the country, and it therefore, without an application, that would not go through. I want to now go specifically into the requirements. Why we require, what we require, and why we require it. Obviously, we require a copy of your HREC approval. As Prof. Musa has indicated, that if it is pending, then at least a letter of application. Most of the time, as soon as you log on to HREC or to any other research committee, they usually give you there's a response and an ethics number allocated to it, and then you'll get a provisional that it is still in review, and they'll let you know the outcomes. Now, although we don't look at the ethics of the study, as we are not an ethics committee, we rely on them to having attended to all ethical issues, but we still look at that to see whether there was anything that may have been overlooked by the ethics committee in terms of our district itself. We require SAPRA approval. That is, if you are using any new medication or investigations, or for whatever other reasons you require SAPRA approval. So you need to make sure that. Then we require a copy of your full research proposal. Now, most of this is uploaded when you put it into the Nhrd website. So we will get access to your complete proposal from the Nhrd website. Now, here is where we come into in terms of the summary of the research. In the Nhrd, it asks for a summary. Now, a summary doesn't mean to say that you take your protocol and you edit it and clip it and just stick in the whatever is required. We have to review your research. We have to look at it and decide whether it's, what, and the relevant things that we want to know in order for us to approve a study is, what is your research question? What are you asking? Is there something that can be answered in the district? Are you looking for the right place for the data to answer your research question? Why is there a need for the study? We need to know why you think it's of value and what will be and later on what would be the benefits. We want simplified your aims and objectives. Now, sometimes in some protocols, you get, the aims and objectives are multiple and complex and complicated. We'd like you to put it in simple terms. What is your aim? What are your objectives? And what is your methodology? How you intend recruiting your samples, simply. Your sampling, who are you sampling? What type of patients or staff, etc., that you are including? We'd like to know your inclusion and exclusion criteria. This is important because we'd like to know whether you're including vulnerable people, people with certain types of disabilities, because that's going to guide us in terms of the risk of the research and we'd like to know what procedures you will be doing. Again, obviously, we need to know your procedures because we'd like to know what impact that would have on the current system and whether it would disrupt the system in any way. Okay, so that's in terms of your summary. As this thing, it's simple. It should be done in a way which we can, squeeze through it quickly, and that will guide us in terms of the risk of your research to the district health system. As Prof. Musa has indicated, we need the list of your facilities, and we need the exact facilities in that district. We need to know exactly which clinics you plan to do. And as Prof. Musa has indicated, that we plan that going forward, that the district hospitals, especially for Johannesburg region, which will be Malangeni, Southern, and Edenvale, will fall under this research committee, but all other hospitals are not included. They all have their own research committees, and you need to apply to them individually, to the research committees. We need your project timeframes for obvious reasons. We need to know how long you're going to do it and for what, and when is your start and end date. Now, why are we asking for this thing in the Nhrd? It asks you to do an assessment of the risk to the facilities. So we want to know, and why we are, some of those questions are, we want to have an understanding whether your research or your project will have any impact or create any additional load on our district staff. Example, are you going to use them to recruit your study? Are they going to be conducting the clinical assessments on your behalf? Are you going to be doing special investigations? What sort of special investigations, and what impact will they have on the services? And are you going to be involving our staff in any of your administrative tasks? We need to know that. We need to know what the resources in the facilities you are going to be using. For example, are you going to be using consumables such as swabs, gloves? Are you going to require the use of the equipment of that clinic, the blood pressure cuffs, needles, syringes, etc.? What space are you going to require? Do you require a separate space in which to do counseling? Do you require rooms which can offer some form of confidentiality, etc.? This is important because we have limited space in the district and we need to know what impact. Are you going to be doing any laboratory and special investigations at the facility? And will you be using the couriers from the clinics to transport these facilities to the laboratories? We wish to know also what impact will your study have on our patients. Will there be a need for additional outpatient visits by your patients? This is important because we have already an overload of patients in the district, in the clinics. We have far too many patients attending clinics, and if your research means additional OPD, we need to know what the challenges at the moment. Is there a need for admission of these patients? If there is, where would this be occurring and how will this be facilitated? And more importantly, does your study enable or vulnerable persons? Important for us to understand this. And then in other broad categories, we want to know, does the study require access to specific people or positions? Means, are you going to involve the head of department? Is it from that to clerks to nurses? Who are you? Who are the people that you? These are qualitative studies, are done in focus groups. You need to know who are the staff you're going to impact, how much time is required of them, and when will stream. Are you going to use this clinic to recruit? Are you going to do this by announcements, handing out leaflets, etc.? And then also, as Prof. Musa indicated, does your study require any specific data or information from the Department of Health? We need to know because, as you said, the repertoire for these data may not be at the clinic, and it may be based more at a central place like the regional offices. So we need to know that, and we need to then direct you to the appropriate place to seek that information. Now, all of this the reviewers are going to consider, and they're going to then try and categorize your study into various risk categories, where there's no risk to the facility, there's a low risk, medium risk, and whether it's a high risk. And these are based on what are the risk factors which I previously mentioned. It's important for us to know this. For one, it helps guide the research committee as to who should be reviewing your protocol. Obviously, more experienced people and people with a bigger, more experience in both in the system and in risk would be to consider the risk ones, whereas those that are probably reviewers to consider. And also it helps to improve the turnaround time so that those with high risk, low risk do not spend too much time, and they can be reviewed much quicker than those that are high risk. So these are some of the things, or these are the things that is required, and I'm explaining to you, trying to explain to you why we require it. So when you are filling in the form on the Nhrd, just take cognizance of this and try to put that information, because it will help us to try and fast track your process, and also to guide you into whether you would anticipate any challenges, or whether this is not
So I think Prof. Musa got cut off there.
feasible in the district, and you might then want to reconsider and review your protocol. Correspondences relating to your research with the district research committee. So anything going forward must be in relation to the Nhrd application reference number. Now, we also, as we said, we want to facilitate research in the district. We want to try and mobilize and build research capacity. We want to identify specific research priorities, and we want to lobby the research committee and potential funders. Therefore, we require from you, when you're filling in to complete where they ask for the health category, this will help us to make sure to understand what are the various categories of areas of research. It will, one, establish whether it is, again, whether it's feasible, whether what type of reviewers should be considered. Obviously, if you are looking at something which relates to, say, oral and, or say, mental health, then we would prefer to ask a reviewer with experience in mental health to consider this proposal. So that's useful for us to know what is your research, and also the area of the research. Are you looking at in prevention of disease, or are you looking at evaluation of treatments and therapeutics? This will just help us to identify the appropriate reviewer to consider your research. In terms of the source of funding, it's useful for us because if we are going to promote research and to try and find possible funders, we'd like to know what are your sources of funding, because it may help us to guide and to approach such funders to facilitate research which may be not driven by research, but driven by the health systems. All of this will help us to identify where they are, or maybe when we identify certain areas that require research in our district, then we can approach also some of these funders or the researchers to consider doing research in areas which we think that will be of value to both to the researcher and to the system as a whole. And I think, in a nutshell, I think we mentioned the fact that if we are going to utilize the research and benefit from all of the research that you run, apart from a degree or apart from any other reasons, your progress reports, your completed reports, your publications, and participations in the webinars will make this, so it will allow the opportunity for feedback to the providers of the services, so that they in turn can improve or benefit from some of the outcomes of your research, and we can make the experience for healthcare users better going forward. So I think that's it. I thank you, and if there are any questions, you're welcome to ask.
Thank you, Yusuf. I don't see any questions yet. Feel free to post some questions. Yusuf, what sort of common errors do you find yourself, do we find ourselves encountering in reviewing, some of the common things?
In terms of, experience in past, one of our biggest problems and challenges, as everyone has probably commented, is the turnaround time. And that was because, the system was poor and it was very complicated. There was a requirement for the researcher to submit his protocol, his ethics approval, and there was a requirement to submit all of that with the hard copies to a district office. And I think now with technology and with the systems that you've put in place, that will improve the turnaround time. In terms of the research itself, I think one of the common errors is that people are unaware, and we're not aware that the district research committee is when you apply to the district, it is specifically for clinics in the district and for district hospitals, but all others need to be done. That there are different ethics research committees for each of the hospitals and each of the other different districts, and they need to apply to all of that. So that was one of the problems. The other concern was, the other things that we would find was that in terms of the researcher in his proposal, not clearly understanding the district that they are working in. As you said, if you're going to do research in a district, you need to understand the system. You need to do some homework, and you need to look into it to see whether the resources or whether that data is available there and how easily available it is, and also whether some of the resources that they need is available at that district. So do a little bit of research before you embark on a proposal. Get in touch with people in the district, if it is depending on which discipline you're looking at. And then if you do that, it makes your task easier going forward, not only in getting the permission from us, but in actually achieving your main objective, which is a completed research. So it would be beneficial for you for that. Other than that, I don't think we had too many it was that complex systems would be submitted, and then that would delay the process. But I think now with technology and with the new system that you've put into place, I think we will overcome a lot of that. And as you quite rightly said, we should be able to have a quick turnaround time. That's it.
No, thank you. Yeah, thank you.
The question that is posed here was, how do we obtain permission to approach facilities for groundwork? I think you need to ask yourself, if you're going into a facility, you need to ask yourself, where is your research? What is your research you want to do? Say, for example, you want to do research in mental health, and that's my area of. Then the obvious person is find out from the district, who is the person responsible? In which case you'll discover it's me. And then you can approach me to ask, this is what I intend researching this way. If it is something that is clinical and involves family medicine on a clinical, then, you would be the person to approach would be Dr. Aki or Prof. Jhb Musa. Similarly, the same thing would be in terms of any other of the other disciplines. There's always someone in charge, and you might want to approach that person to get an understanding of what the facility is for that. Obviously, no clinic is going to allow you to walk through the facility and talk to various people. So either the facility manager, and if you know more specifically what discipline, then trying to find out who is the clinician or the professional that's responsible for that discipline. And then perhaps you can get a better understanding of the groundwork that is required.
True, and I think that if you are wanting to do any pilot work, you should include it in your research proposal. I think that's generally helping you, and I'm sure adjustments is something that we can cater to as part of the ethical approval. So I think, you know, those are some of the issues. I think just want to mention one other is the question of trying to get information. Now, we've had one specific challenge where people want to get information of patients, not anonymized. In other words, they want the information from us of patients to then do recruiting in the community or recruiting in the facility. Please understand that these are patients who are needing the respect because they are autonomous. We hold that information. For example, their contact details, we simply cannot share it. It's the same as any researcher walking up to your doctor and saying, can I get your details because I want to contact you? POPI Act prevents anyone from simply giving information that they have collected for the purposes that you agreed to give them the information to now use it for other. So we don't collect information like that for research purposes. We collect it for the administrative purposes. So just understand the limitations of law in being provided information. I know that's one that's popped up, but I think in any of the situations that you are in, you're not going to necessarily do research like Groundwork. Groundwork is not doing the research. Groundwork is asking questions about how you can do the research, what is possible, what is available. And these are questions you can ask, and nobody is going to stop you. And if you have any difficulties, email Busi to me, and then we will basically try and support you. We are here to support research. We are not here to block research. We're trying to facilitate it simply with the conditions that Yusuf has pointed out. As long as it does not cause problems, we are happy that research is done. We'd love to direct it. We'd love to work with all of you eventually to see whether we can encourage research that's more appropriate for the facilities, for the system. And I'm sure that you'd be also just as interested in that kind of outcome where it can make a real difference in people's lives. So I think, thank you for that. Yusuf, before we move to the first presentation, thank you, Yusuf, and you'll be leaving us shortly. I really appreciate
thank you. I just want to, there's a question in the chat, just to quickly, if a researcher is not doing a research towards a degree or linked to any institution, which ethics committee? I think as far as ethics is concerned, if you're, it doesn't matter. If you're doing any work on human subjects, you have to get one of the registered ethics approval. So I'm not sure if whether it's a degree purpose, non-degree, not linked to any, if it's just a individual researcher, you have to get ethics approval if any research is being done on human subjects. And any research committee is available to do that research.
Well, if you go through now and just Google registered ethics committees, the National Health Research Ethics Council publishes a list of research ethics committees. Please, I urge you to go and make sure that the committee that you're approaching does indeed have that. We do have challenges with some of the ethics committees in what they're kind of approving, where when we see the kind of what's coming through, there are challenges, but that is not your problem. We'll talk to the ethics committees as long as they're registered, and please make sure that you work with only registered committees. Before we, and Yusuf, thank you very much. I'm going to just quickly.
I'll excuse myself. Thank you very much.
And thank you, Yusuf, for joining us. Right, so essentially the other thing I just want to mention before we move on to Andy Kim, is that you try to, I just want to share my screen so that we can show you, sorry, give me a second. On the NHRD, this is the actual form which you've submitted, probably see what we get. This is your application form that's come through. I really urge you in the aims and objectives that you use that as a neat, small summary of your research. Aims and objectives are just too thin. It's the only space we have to understand your study in sum. Otherwise, we have to read the entire thing, and sometimes we really battle trying to find it. So make your own life easier. Tell us in that sum of aim and objectives, what is the research all about? Like an abstract, what you plan to do, what is this research about, what's your rationale, and even your study design, etc. We specifically, the other thing that we would like to see is your sampling. Now, sampling in specific, we often get challenged, is you don't spell out exactly who and how you are going to do it. We get a lot of people putting in the sampling theory without, and that's not what we really need. That's there in your protocol. We assume it's scientifically done fine. Our difficulty lies in you actually telling us who and how are you going to find these people that you want to sample. And so be very clear and specific. I'm going to go and look for these people, every fifth person in this clinic, in the outpatient department, or I'm going to interview these particular managers in this specific facility. Just be clear and tell us, who do you want in that sample? And it helps us especially understand the impact you're going to have, because this is where we can tell you, this is going to be a challenge, or know the impact that it's going to have, or whether it's practical or not. So please be specific in these two spaces, aims and objectives, and a summary of your research sample. Be very specific about who you want and how you plan to get them. Okay, we're just going to stop there. I'm going to start the webinar, the second half of the webinar, to share, I think, pieces of research that have been done. We're really grateful to the three presenters that have committed to providing us their studies, insights into their studies. I'm going to ask Andy Kim to talk about evaluating mental health impacts of the COVID-19 pandemic in urban South Africa, perceived risk of COVID-19 infection, and childhood trauma predict adult depressive symptoms. Andy, if you don't mind introducing yourself a little bit more, and also telling us more about what you're going to do. We're going to do this in 20-minute slots and includes a Q&A. So please get your Q&A up before we finish the 20-minute slot so we can try to answer it. Otherwise, we'll have to move on to the next one.
Great, thanks.
Thank you very much.
Yeah, appreciate it. Hi, my name is Andy Kim. I'm a PhD student at Northwestern University studying biological anthropology, but I'm currently based in Johannesburg, where I currently work with the Developmental Pathways for Health Research Unit, which is a MRC-funded research unit with FITS located at Baragwanath Hospital. Today I'll be speaking to you about our attempt to analyze the mental health impacts of the COVID-19 pandemic, specifically in Soweto. So I'll go ahead and start the presentation. All right. So we're all pretty familiar with the course of COVID in South Africa, but just to give you a brief primer, so the first confirmed case of COVID was found, detected on the 5th of March 2020. 21 days later, the president commenced the South African lockdown, which began with level 5 and changed over time based on this risk-adjusted strategy. And even before COVID came to South Africa, there were already pre-existing concerns around the high rates of comorbidities across our country, specifically non-communicable diseases like hypertension and diabetes, as well as an elevated rate of infectious disease, specifically HIV and other infectious diseases. In addition to this, we also know that COVID was coming into South Africa at a time with elevated rates of poverty, unemployment, and just social adversity in general. So these two things together kind of was a cause for concern for the potential impacts of COVID-19, the pandemic specifically in South Africa. So these are figures that I got this morning from Becky Cisa's website with our partnership with MediaHack, just to give you a sense of where we are in terms of the pandemic. there have been approximately 630,000 confirmed cases. Over the past month or two, we've started to see the number of daily infections and confirmed cases decrease, which is wonderful. The number of deaths that have been reported is around 14,000, which is much lower than the estimates that was provided by the modeling team in the beginning of the pandemic, and close to 4 million tests have been conducted, which is fantastic. So if you look at the figure on the right, these are also figures that I took this morning. These are 7 different regions of Gauteng that have been disaggregated to try to understand regional trends of COVID. And as you can see here, Region D is by far the most affected, and this includes Soweto, which is a specific area that I'll be talking about today, as well as other surrounding areas. So we see that Soweto, or Region D, had the greatest number of confirmed cases, and we also see that across all regions, the curve is definitely starting to plateau, which is wonderful. So we also knew that the state of mental health in South Africa was also a particular cause for concern before and during the onset of COVID. So in general, it's estimated that about 1 in 3 individuals will be diagnosed with a mental illness in their life. About a quarter of cases are severe, yet only a quarter of those cases actually receive treatment. We have a very low percentage of medical aid enrollment. And all these statistics just go to show that the mental health system, specifically the public mental health system, is overburdened and under-resourced. There have also been a number of concerns now that we're well into the pandemic that pose various threats to one's mental health. These include the conditions of quarantine, as well as the economic and social ramifications of lockdown, so people losing their jobs or being unable to work. People's inability to adhere to risk mitigation strategies like quarantining and social distancing, different adverse conditions. So we saw that militarization was a tactic that the government used in the beginning that was rather severe and definitely had a number of unfortunate implications, especially among low-income communities. And again, all these sort of conditions existed upon this pre-existing state of high rates of mental health morbidity, and a landscape where there are already existing threats to mental health, like limited access to healthcare, prevalent drug use, untreated mental health conditions, things of that nature. And finally, we see that with the actual infection of COVID-19, a variety of neuropsychiatric sequelae have been reported. We recently released a paper in the Vitz Journal of Clinical Medicine that provided a review article on the psychiatric impacts of COVID-19 infection. So this is a figure that comes from SADAG, the South African Depression and Anxiety Group, which is the largest mental health NGO in the country and also runs the largest call center. And as you can see here, the number of calls have more than doubled between times before the pandemic to where the figure was now. So the last estimates were calculated for June. So SADAG has definitely seen a massive increase, but also a massive burden on their health system, or their call center, we can really conclude that at the level of the number of calls that they're getting, there's definitely an increased impact, likely due to the lockdown. So this brings us to our study question: what are the mental health impacts of living through the COVID-19 pandemic? And I specifically specify that we're evaluating the effects of living through the pandemic rather than COVID-19 in of itself, because at the time of the study, no one is actually affected by COVID-19. And like I said before, our study was based in Soweto, South Africa. Probably don't need to provide any sort of background information about Soweto, but located southwest of Johannesburg, a massive mixed income township. And we worked off of an existing epidemiological surveillance studies on comorbidities. which was running between April 2019 and March 2020. As I mentioned before, our research was based on the Developmental Pathways for Health Research Unit, which is located in the campus of Baragwanath Hospital, which also is located in Deep Kloof in Soweto. During this first wave of data collection, which was pre-pandemic for about a year, we did door-to-door sampling across a variety of randomly selected geographic sites across Soweto, and recruited 957 individuals for this study. After the lockdown, we quickly submitted an ethics revision or ethics amendment to VITS and received approval to do a follow-up of these 957 adults telephonically. And for the data I'm presenting today, the trends come from the first 6 weeks of lockdown, so the end of March to around early May, which covers the entire span of level 5 and a week of level 4. In total, we recruited, or we contacted 339 individuals, but only 221 adults reported full data and made it to our analytical sample. So to give you just a summary of what our study looked at, or what data are available, in wave 1, we had a series of surveys that assessed demographics, health inventory, previous mental health status, as well as different social conditions or social environments. And then wave 2, we did it was a brief follow-up survey that administered the COVID-19 survey, which we just called, which was a very brief mixed method survey, so a mix of qualitative and quantitative measures that were assessing perceptions and experiences of COVID-19 among adults in Soweto. And then the CESD-10, which is a depression screener, a 10-question depression screener that we implemented to assess depression morbidity. I would want to note that the 2 mental health measures that we collected, the one in wave 1 and the one in wave 2, are unfortunately different. So we weren't able to do direct comparisons, but we do have mental health measures at both time points. So jumping right into our study findings, just to provide a sense of our sample, overwhelmingly majority of people were female. 61% of people reported having some primary school or less. 94% of individuals reported having at least one condition or more. And I just want to note that because we sampled from a study that was exclusively looking at comorbidities, the numbers are definitely inflated, but general population or community-based research also in Soweto shows that there are high rates of existing comorbidities. The average age was 46, and we created a measure, this household density measure, evaluating the ratio of number of people in the household to the number of rooms, especially since we know that COVID is, very transmissible through close distance and touching. So the average household density was 2.2 individuals per room. So the first set of findings I want to share are a summary of perceptions and experiences from our COVID-19 survey. And I want to again emphasize that this is from the first 6 weeks. So we know that the course of COVID has had hit Soweto way later, or a little later, I would say, than in the northern suburbs in Johannesburg, where a lot of the cases first started to rise. So at this time in Soweto, COVID-19 was definitely in the news. Obviously the lockdown had started, but in terms of active infections in Soweto, those cases didn't really start to appear up until, like, I would say mid-April to May, and then of course until now. So during the first 6 weeks, nearly 100% of our sample had heard of coronavirus. Only 1.4% of individuals actually tested, which I think was around like 3 individuals. They were all negative, thankfully. And we created this prevention score, which was basically a summary or a summed measure of 12 different public health approved prevention techniques that we asked people whether or not those practices actually prevented COVID-19, and we created this 12-item measure. So on average, 7 out of 12 individuals, on average, around the 7 of the out of the 12 questions were answered correctly. So these are things like, does wearing a mask prevent against COVID infection, social distancing, things of that nature. And finally, we asked, do you think you have the same risk as others in your community? And specifically, we were asking people if they believe that their risk was the same, greater, or lower than people in their neighborhood in Soweto. And we found that the majority of individuals perceived their risk to be lower. 29% said their risk was the same, and 13.5% said their risk was greater. So we want to wonder what led to these different discrepancies in perceived risk of COVID infection. So for people who said that their risk was greater, most of the individuals had reported saying that they were either a frontline healthcare worker or still required to go to work. So people that worked at Checkers or other shops, and also the sense that or people reporting that in their neighborhood, people were still not necessarily adhering to the COVID-19 mitigation strategies. So that's what we see among people who reported greater risk. People who said they had the same risk reported both positive and protective risk and protective factors, so things like adhering to social distancing, but also not having space to social distance. So obviously it was kind of a mix. But when we try to see what ideas led to people reporting why, thinking why they had lower risk, a lot of people talked about basically adhering to these government strategies or approved strategies like staying at home and social distancing, wearing a mask, hand washing, which also goes to show that there was definitely uptake of these public health measures, and those did drive. We perceive that they did relate to people thinking that their risk was lower. So this is just a quick summary of the mental health status in between wave 1 and wave 2. Again, wave 1 was 1 year before lockdown began in late March, and wave 2 was the first 6 weeks of lockdown. In wave 1, we assessed psychiatric risk using the GHQ-28, which is just a measure of psychiatric morbidity, and we saw that 41% of individuals met the cutoff for greater psychiatric risk. We created this ethnographic derived stress scale, which isn't necessarily comparable, or is not comparable to other measures because it was locally developed, but our measures showed that there was a moderate amount of stress. A portion of individuals reported food security in the past year, and rather high rates of childhood trauma assessed by the ACEs. As well, and thankfully, moderate to high levels of reported social support, which was also developed through an ethnographically derived measure. In wave 2, we see that based on the CESD-10, that individuals reported there was approximately a 14.5% prevalence rate of severe depression. This is not a clinical diagnosis, but merely a screening tool. But we still did find a portion of individuals reporting depression risk, which doesn't seem to actually be higher than previous rates before the lockdown, according to other studies. Relatively, as I mentioned before, a majority of individuals said they had lower risk than others. And when we asked people whether or not COVID-19 affected their mental health, or specifically we asked if it affected their mind, because not a lot of people resonated with mental health, a majority of people said no. So in keeping this in mind, we wanted to dig into that and try to identify other factors that led to this. And despite 74% of individuals reporting that it did not, that living through COVID-19 did not affect their mental health, we still had a decent portion of people reporting really potent experiences of anxiety, a fear of infection, as well as rumination. So things related to increased susceptibility to COVID, possibly because of old age or old age of their loved ones, as well as having an existing comorbidity like HIV. And I'm just going to jump through these pretty quickly because I know we're running out of time, but these are our results from our multivariate regression models. Again, just to know that these are cross-sectional with longitudinal covariates. And we see a direct relationship between risk perceptions for COVID-19 as well as depression scores. So the greater perceived risk of COVID-19 infection is associated with more severe depressive symptoms cross-sectionally during the first 6 weeks of lockdown. And we decided to run an interaction term between perceived risk and childhood trauma based on our a wealth of knowledge that shows that greater adverse experiences during development, during child development, predisposes individuals to greater stress reactivity, which thus potentially leads to worse depressive outcomes. And our evidence suggests that that may be the case. So the higher perceived risk of COVID-19 infection is associated with greater depressive symptoms, particularly among adults with histories of childhood trauma, which we see in these like black and red lines. We didn't pass the 0.05 significance threshold, but this definitely trends in the direction that suggests that there's an interaction, and also maybe an issue of sample size. So just to close, just wanted to mention that the particular pathways that may be leading to greater COVID-19 infection or the mental health impacts of COVID-19 experiences may be developmental due to pathways of childhood trauma and future mental health status. Of course, all these conditions are grounded within these very salient legacies of apartheid and ongoing structural violence like poverty and unemployment, which a lot of our participants had noted. And all these data just kind of go to show that greater emergency psychological resources and sustainable improvements in the mental health care system are very much needed, not only during this time, but especially moving forward. So I'll just close there. Yeah, thank you for your time.
Thank you very much. Appreciate that. I just want to say thank you. And we, my experience and as a family physician in, responsible for Soweto, a lot of the patients are actually quite stoic. They don't share, they think sharing their mental health challenges is a bit of weakness. So thank you for that. I think it's really useful to share. I'm going to leave you, Andy, to just respond to 1 or 2 questions in the group chat. I think that'll be great. In your email, I think people would like to take it up from you. Let me move to Simon. Simon's going to talk about, sorry, let me just get to Simon. Simon's going to talk about the management of severe acute malnutrition in children aged 6 to 59 months by professional nurses in primary healthcare facilities in the Johannesburg Health District, a retrospective analysis. So Simon, please share a little bit about yourself and then tell us about your study. And Simon, you'll just keep the time as well. I'm trying to catch up on time. So let's keep it to about 15 minutes at max, and at least allow some questions. Thanks. Simon, able to share? So there was a hand up, and unfortunately we won't have enough time for that. Simon? Ah, there you are. And Simon, you can put your viewed video up so we can people can see you. Wonderful. Carry on, Simon. Thank you. Sorry, Simon, I think your video, your audio is slightly challenged, or maybe just we can't quite hear you. Try again. Just say something. No, we're not hearing you. All right. Simon, let's just, if you don't mind, I think sort of getting out and getting back in and fixing it up. In the meanwhile, let's ask Sinead. Sinead, if you don't mind just carrying on so that we save on time. And Simon, if you could just go out and come back in, I think it'll help you to get connected better. All right, thanks, Simon. You can just, mute and Sinead, go ahead. So Sinead will talk to us about the potential for MMR vaccine to prevent symptomatic COVID-19, plans for a randomized controlled trial. It's a still study that she's busy with. So Sinead, over to you. Tell us more about yourself and then tell us about the study.
Great, thanks very much. I hope you can see my screen.
Yes, thank you. Great, we can hear you well.
Okay. Good afternoon, everyone, and thanks very much for the opportunity to talk to you. My name is Sinead Delaney Moretwe, and I am based at Wits RHI, where I'm a director for research, and I'm also a research professor within the Faculty of Health Sciences at Wits. And I'm really pleased to be able to talk to you about the Coronation trial, which is a trial that is evaluating a range of interventions for the prevention of COVID-19 in healthcare workers. And I know a number of my colleagues who are participating in the trial are on the call as well. So I don't think I need to tell anyone, and I think the colleague who spoke prior to me has already alluded to this, that SARS-CoV-2 is a significant public health threat. And part of the reason for that is that we, as a novel pathogen, we as humans don't have prior immunity to this infection. And for that reason, we've seen very rapid transmission within communities. And what we've seen is a wide spectrum of disease, with the majority of people having mild or self-limiting disease, but a proportion of people, about 20%, have gone on to have severe disease that may require hospitalization and intervention. And today, we've had about 25 million cases globally, with a substantial number of deaths, about 858,000. And as you heard my colleague speak previously, there's also been, along with just the death, the enormous social and economic disruption that's been associated with the lockdowns. The way our children go to school, the way we interact with each other has changed substantially. And of course, globally, the economies have been impacted, and all of this has severe consequences for us in the long term. And because this is a novel pathogen, we have very few proven pharmacological interventions, either for treatment or prevention. Given the amount of information that's swirling out in the ether about things that do or don't work, I think we, as scientists, believe that it's incredibly important that we conduct trials that are going to provide robust data that really can inform public health programs about what works to treat and or prevent COVID-19. So the goal of this trial is really to determine the effectiveness of select interventions in preventing symptomatic laboratory-confirmed COVID-19 in healthcare workers who are exposed to SARS-CoV-2 during the course of their work. And the outcome is measured at 60 days. So why are we particularly focusing on healthcare workers? Well, I don't think I need to explain to those of you on the call that healthcare workers are vulnerable to COVID-19 for a variety of reasons, including the fact that during work they may suffer repeated exposures, either because of the numbers of people they see or because of the size of inoculum that they're exposed to if they're doing for example, sputum-inducing procedures or other procedures that might generate aerosol. But also we've observed from studies that healthcare workers may just be exposed during their travel to and from work, or because of community transmission, where they, I think we heard the presentation, people going to work when others are not. And also we know that PPE is not infallible. And I think the biggest concern for us is that healthcare workers are an incredibly important part of our social fabric. And we've seen from other epidemics, like the Ebola epidemic in West Africa, that impacts on healthcare workers who become ill really impact on frail healthcare systems. And so it's of critical importance that we look for interventions that can protect healthcare workers during this time so that they're able to sustain our response to the pandemic, but also so that they're able to maintain the healthcare programs that are equally important, like for us in South Africa, our HIV program or our TB program, or even the programs for non-communicable diseases. So what is the Crown Coronation trial? It's an international multi-site trial. It is a platform trial, and I'll explain what that means. But essentially, in a platform trial, you can start with a set of interventions, and you'll see there in a treatment A, which is compared to a control group. But over time, as new information emerges about new interventions that may have the potential to prevent COVID, we can add in additional treatments. And all of those treatments are compared to the same control group. And this is considered an efficient way to answer questions, particularly in the time of a pandemic where speed of results is incredibly important. This is a Bayesian adaptive trial, and what that means is that in this type of approach, we will be able to review the data fairly regularly, and we will be able to identify treatments or, interventions that are working well to continue, but also drop any interventions that appear not to provide benefit. And that's considered another sort of efficient part of the design. And this trial is going to take place in the USA, UK, Ireland, Canada, but also in several countries in the African region. And it's one of the few trials, in fact, that is evaluating interventions in the region. And in Johannesburg, there are a number of research entities which form part of Wits University that are going to be involved in this trial and hope to recruit healthcare workers from the city of Johannesburg. So I think originally when this presentation was advertised, it was advertised as a trial about chloroquine, and Shabir suggested I mention why we decided to pivot away from chloroquine. So I think there's been a lot of debate about chloroquine. There have been some very high-profile presidents promoting the use of chloroquine for COVID-19. But I think when we reviewed the evidence a couple of months ago, we recognized that there was limited evidence for benefit as a treatment, and that particularly there were concerns about safety in hospitalized patients who were severely ill. And this was probably related to the dose of drug they were getting, but also the fact that many of them had underlying comorbidities. And often because of that, they were taking multiple drugs, and that these drugs might interact with chloroquine and lead to some of these negative effects. And so it was with particular interest that we saw the decision of WHO to stop the chloroquine arm in the Solidarity trial. And they did that on the basis of an interim review from 2 big trials, which are also platform trials, which basically showed that there was no additional benefit of chloroquine in terms of preventing mortality. And that was really the goal of those trials. And so they stopped the chloroquine arms. So that was for treatment. Our trial is to do with prevention, but we think that the fact that there doesn't appear to be any virological effects when it comes to treatment are important for informing prevention. We also reviewed data from animal studies which showed no benefit for either treatment or prevention. And then a couple of months ago, 2 large trials of using chloroquine as PEP showed that there was really no significant benefit in terms of prevention. They showed very modest effects, about a 10% reduction in infection, and that was not statistically significant. And what they did observe is that in those people who were in the chloroquine arm, they did report a high proportion of GIT side effects. And for us, it's really important to, in prevention to weigh the risks versus the benefits. And we felt that the benefit, which would have translated to a number needed to treat of between 100 and 200 people for every 1 infection averted, balanced against quite significant GI side effects, that it probably wasn't the best preventive option. And then I think the straw that broke the camel's back was really that we saw a notice from the FDA, who issued a warning about the potential for drug interactions between chloroquine and remdesivir. And although we didn't plan to use these drugs together, chloroquine has a very long half-life. And so that might have meant that people who did get COVID infection might not have benefited from remdesivir if they'd had chloroquine, and that is a very important consideration in terms of access to treatment for people who might use prophylaxis. So it was for these reasons that we decided to drop the chloroquine arm before we even started. And so after some consideration within our consortium, we have decided to use this platform trial really to ask the question, can vaccination with measles, mumps, rubella vaccine prevent symptomatic COVID-19? Now, I can imagine that you're all asking, why would an MMR vaccine have the potential to protect against SARS-CoV-2? And there's some really interesting both observational and biological evidence that's emerging that I'll just go through with you. So firstly, there's ecological evidence. Essentially, that's evidence that shows that COVID-19, rates of COVID-19 severity appear to be lower in countries that have higher rates of MMR coverage. And it's also speculated that maybe children under the age of 10 are getting less severe COVID-19 because they have a recent history of vaccination. A lot of these effects are thought to be attributed particularly to live attenuated vaccines. And we have observational evidence for actually other live attenuated vaccines, so both BCG and oral polio, that show that generally these vaccines are associated with decreases in all-cause mortality. And this is data that COVID era, but data from West Africa and also countries in the Northern Hemisphere showing these non-specific effects of these live attenuated vaccines. When it comes to MMR, there's some emergent data from US Marines who are routinely vaccinated when they enter the US Navy. And there was a study conducted in sailors who were on the USS Roosevelt, which is a ship, where they found that amongst nearly 1,000 sailors who had been tested for SARS-CoV-2 and found to be positive, only one of them needed hospitalization, and this seemed to be associated with a history of vaccination. So this was all tantalizing data, and since then there's been a very interesting paper presented in medRxiv, so it's still under peer review with a journal, but it provides further tantalizing evidence. This is a very large data set of electronic health records from the Mayo Clinic, which cover countries globally, where they looked at over 137,000 individuals and basically had data on their SARS-CoV-2 testing outcomes between the period February to July. And using a propensity score analysis, they looked at people who had a history of vaccination versus those that didn't. About 2/3 had a history of vaccination in the past 5 years, and their test outcomes. And what they showed was that those that had been vaccinated with MMR had a 47% lower risk of SARS-CoV-2 infection, and this was statistically significant. So this provides us with tantalizing data, and people have asked, well, is this a real effect? And there is some biological evidence to support this. And this really comes from a concept known as trained immunity. And that relates primarily to our innate immune system, which is the primary response of our immune system when we're exposed to a pathogen for the first time. Our innate immune response responds. And the idea is that with an MMR vaccination, you can induce an innate immune response, which then leads to cells in the bone marrow essentially being reprogrammed such that they can produce immune cells which are much more able, when they're exposed again to infection, to control those infections. And this has been shown for a number of live attenuated vaccines, and is the idea or the hypothesis behind which we may be seeing this mechanism. The second is a more familiar mechanism to you, which is that of adaptive immunity. So these vaccines produce antibodies, and there is a fair amount of cross-reactivity between the antibodies for MMR and those that could attach to SARS-CoV-2 and address that infection. So there are two mechanisms, but the one that's most likely is the trained immune response. So with this evidence, it really becomes important that we test this in a trial so we can see whether this could work. But I think one of the big questions that a number of people have asked is why would I take a non-specific vaccine? And I think this is a critically important question, but for a pandemic like COVID-19, we really need prevention interventions rapidly for healthcare workers, but potentially for other frontline workers. And these interventions are potentially inexpensive, they're readily available, they're simple to administer, it's a single vaccination, and we have an extensive safety database on MMR. And this is in contrast to the SARS-CoV-2 vaccines, which are being evaluated, but none of which have been proven to be effective yet, and for which we don't know the safety profile. So if we see results from these trials, this may be useful for scaling up prevention interventions while these other vaccines become available and are developed. And we also think they may have the potential to be combined with specific vaccines, but because this is a non-specific effect, it may also be useful in future pandemics. And I think the world has become much more anxious about future pandemics. So who can join this trial? Essentially, we're recruiting healthcare workers who are 18 years or older and willing to give consent. They must be working in an environment where they are potentially exposed to SARS-CoV-2 and where they have no contraindications to the MMR vaccine. And this is very much a light touch trial. Most of the procedures, apart from vaccination, are done remotely. Participants are followed up weekly via SMS for details about symptoms they may be experiencing. There's also a longer phone questionnaire once a month, and they're provided with a kit so they can self-swab if they become symptomatic, and we can identify if people have infection. If they do have infection, we link them to care, depending on the severity of their infection. And for people who want more information, there is a website for the trial, Coronation. It has a lot of information and has specific links to the South African site, which will become activated, I think, once we receive our approvals. So in summary, what are the potential benefits? We think that there are a number of benefits. There are direct benefits to individuals, although in South Africa, we know that measles, MMR, vaccination status is fairly high, or people will have been exposed to infection as children. But there is the potential to be protected against SARS-CoV-2. And there is the potential that this vaccine may assist in future pandemics as well. And either way, I think this is going to provide important information which will help us understand whether this approach of heterologous vaccination does have value in the context of pandemics. So we're looking forward to launching this trial in South Africa in the coming week, pending our approvals. We have been in touch with SAPRA and a number of ethics committees in the country and are looking forward to crossing the finish line in the week. And we look forward to further engagement with the city of Joburg and are very grateful for the presentation today, which I think has highlighted, kind of how we can expedite approvals for this, but also as we add future interventions to the platform. So just to acknowledge the COVID Therapeutics Accelerator, which is funding this trial, as well as the South African MRC and the partner institutions across the world, which have really been responsible for generating, I think, what is a very exciting trial. Thank you very much for your attention, and I'm happy to take questions.
Yes, thank you very much. And I think that this sounds like a really great project. Let's hope the coronavirus doesn't disappear before it starts. So we need to really get it happening quickly. But thank you. There's some questions. I think Namaswasi Gabela asked about inclusion, exclusion criteria. I'm assuming that everyone gets a vaccine booster, or is it based on them being already vaccinated, Sinead?
Yeah, that's a great question. People are randomized either to the vaccine or to a placebo vaccine. And there's no exclusion based on history of vaccination. We will collect samples that will let us know whether people had antibodies to vaccination at the time of enrollment. but it's not a requirement.
Sounds great. Good. Thank you very much, Sinead. And I think you'll put out your details so people can actually email you if they want more information or engage if the site is not good enough. But I think you've got a website there. And really appreciate the sharing. Thanks, Sinead. Let's go to our last presenter, and I'm sure that we'll try and expedite, all research, like I say, quickly, and hope that everything gets to be done as soon as possible. So let's go to Simon. Simon Shabangu, in fact, is, I have his bio, and really appreciate that he sent it out. So Simon's actually in the district, and I'm very pleased that he's actually come forward. He's a chief dietitian working for Johannesburg Health District as the nutrition coordinator. He's completed his BSc in dietetics in Limpopo, did an MSc in Stellenbosch. I'm hoping that this is what he's been doing. But before he joined us in Johannesburg, he's worked in West Rand District. He's passionate about nutrition, clearly, and preventable diet-related death. So over to you, Simon. You need to add more about yourself and then tell us about your study on the management of severe acute malnutrition in children aged 6 months to 59 months by professional nurses in PHC facilities in Johannesburg. Thanks.
Good afternoon, Prof. Can you hear me?
Yes, we can hear you now. Wonderful.
Unfortunately, my presentation, can you just put it on the, because mine here, my computer is dead now. I cannot use it.
No problem. I've actually got it up. Let me just quickly find it. I just saved it just in case. Give me a second. There we have it. Almost there. All right, you just tell me next and we will move. All right.
Okay.
So,
basically, my research was basically on the management of severe acute malnutrition in our district, because in previous years, we have seen that the number of cases of severe acute malnutrition was actually increasing at the DHIS records. But when you go down to the facilities or where the children need to be admitted, then we'll find that there were no signs of those children that were classified having SEM at facility level. You can go to the next one. With introduction, severe acute malnutrition is the devastating childhood illnesses that cause major problems for public health. And likewise, in our district, Johannesburg district, this is it's a huge problem, because in most cases, these children are missed. And then if they are missed, some children have higher risk of death within 48 hours after admission at hospital. Correct classification and management at clinic level is very important. So the care of children younger than 5 in PHC level is guided by the Imci Protocol. So the Imci Protocol management process recommends that nutritional assessment, classification of any problem, appropriate management, and the scheduled monitoring of planned intervention should be done whenever a child attends a clinic. The World Health Organization explained that PHC should be used as an opportunity for disease prevention, health promotion, and detection of disease. So basically, my study was that I wanted to see whether the Imci guidelines for children who are sick, were they being assessed for nutritional status, because the World Health Organization stated that any child who comes with any other illness, we need to check their nutritional status, meaning that we need to check their weight, we need to check their height, we need to check their weight for height. So as I've mentioned previously, that the data between April 2015 and March 2016, we saw a huge number of cases that were classified at clinic level for severe acute malnutrition. But when you go to Baragwanath or admitted hospital, we find that there are less children that were admitted for severe acute malnutrition. So my study basically was on to determine all the children aged between 6 months and 59 months that were classified by for SEM according to Imci guideline. So my study was based on the Imci guidelines. So the children who came for EPI, they were not included in my study because they were not sick. They just came for normal immunization. So we wanted to identify all the children aged 6 to 59 months that were not classified for SEM. But when I look at the records, you find that those children, actually, they were SEM cases. And I wanted to describe the proportion of the children that were SEM cases, but were not referred to hospital for management. And I wanted to identify the number of PHCs that facilities that had nutritional supplement for SEM cases. In this regard, all the PHC, they are supposed to have supplements that are needed for children who either had SEM at were admitted at hospital and now they are recovering. They need to get supplements so that they don't go back to SEM again. And for those facilities, when they see the child that is SEM, they need to supplement those child. So I wanted to find out would our clinics or PHC have those supplements for the child that needs them. Next slide. So with the results, I visited a total of 39 clinics. Out of these 39 clinics, 1,189 clinics files were reviewed. At the clinic level, I will request the files of the children that were sick in the period of April 2015 to March 2016. That was my criteria. Out of that, I only found 83 files which were meeting the criteria. And out of 83 files, 53% it were males and 39 it were females with the median of age of 11 months. So 81% of the in these files weight was taken and recorded, and no growth charts were found in those files. In all of them, there were no growth charts to plot the weight of the child on the growth chart. And then 33% had weight taken. Next slide. 24% had mid upper arm circumference, which is the most crucial for us to classify SEM. We need to have mid upper arm circumference. And one which was added is weight for height. Only 33% had the record of weight for height, and 14% were correctly classified for having SEM. And these are the children which actually they were in my intention to say, out of these children that were classified for SEM, how many of them were referred to hospital? 78% were not referred at, meaning that 78% of the children were not referred to hospital, but according to the information which was in the file, these children had SEM but were not referred. And for stabilization feed, because in the Imci guideline, children who had SEM, they need to be stabilized, given stabilizing feed. Only 2 clinics had F75, which is the one that actually starts to stabilize the child, and 77 or 27 clinics had porridge for supplementation. Next one. So my findings under discussion, I found that the guidelines were not they were not adhered by the professional nurses. In other cases, you'll find that children were classified that are having severe acute malnutrition with only the weight which was appearing, and the nutritional assessment was not part of them. You'll find that some of the children, they will have their temperature, they will have their weight, but when it comes to the part of severe acute malnutrition, or whether the child is having severe acute malnutrition, it was not yet completed. And then the study have found that consistently poor level of classification of SEM using IMCI guidelines. In most cases, you'll find that the professional nurses will only focus on what the mother is saying of the child that is sick. If the child is having diarrhea, they will say the child is having diarrhea, and then they will not probe or check for severe acute malnutrition. And the results of the study show that most of the children in this study were not accurately assessed for severe acute malnutrition. Next one, please. So weight was, as I've mentioned, that weight was the one which was used in most cases for children that are having SEM. And then if with that, according to the Road to Health booklet, weight is only used for underweight for age, not severe acute malnutrition. Weight for length is the one which we're supposed to use for them to classify severe acute malnutrition, including the mid-upper arm circumference. And then in this case, these two were not adhered to. Only weight was the one which were taken and recorded. Poor adherence to IMCI guidelines may lead to failure to identify children that present with SEM. So in most cases, you'll find that because we didn't use the weight for height, and then we didn't use the MWAG, you'll find that those children actually are only referred to Bara or Rahima Musa for any other illnesses, but not severe acute malnutrition. And at Bara, they will only treat for diarrhea, and with that, they will only going to put a drip, and then you'll find that the child will have shock, because now you'll find that the classification was not a correct one at the clinic level. So nurses testing blood sugar, one of the things which they're supposed to be doing is that after confirming whether the child is having SEM, they need to test for the blood sugar, and in most cases it was not done. And then it was found that in some of the clinics that we went to, F75 was not available. And then other clinics, they even reported that they have never seen these porridges that I was talking about. And it's been years that they have never seen such porridges that I was, the supplementation that I was talking about. The next slide, please. So the aim of the study was to evaluate the assessment and the management of SEM in children aged 6 months to 59 months by professional nurses at facility level. Professional nurses did not adhere to IMCI guidelines when they were classifying children who are sick with SEM. The IMCI guidelines were used to assess other sick children, like your pneumonia, like your diarrheal illnesses. Those ones, they were correctly classified. But when it comes to check whether the child had severe acute malnutrition, that one was left out. Only weight was used to classify some of the children to say they are having SEM while they were not having SEM. The results show poor usage of the IMCI chart booklet by professional nurses. And with my recommendations, okay, the other thing is most of the clinics did not have nutritional supplements for children who were admitted at institutions, and then now they are referred back to their nearest clinic. You'll find that the supplements are not there, and then children actually go back to the states where they were before. And then the EPI should, these are the recommendations. The EPI should not focus only on the immunization of the child, because that's another thing that has come out. You find that children were coming to our clinics very early in our facility, but because they are coming for immunization, they only focus on immunization, and then they are not followed up on feeding, and their weight is not followed up to say, now your child is not growing according to the Road 12 booklet. And most of the clinics reported that they have never seen the supplements which I was talking about, especially the ready to use therapeutic feed. They have never seen such a thing. And then this indicates that the district nutrition program is not procuring and supplying the supplement that are needed by the all clinics in order for us to prevent the same deaths that are occurring at our district level. So nutritional screening should be done for all the children when they are coming to our clinics. Whether the child is coming for EPI or the child is coming for the IMCI, the child is sick, weight, height, mid-upper arm circumference, it should be one of the things which are in the files of the child. Professional nurses should identify and treat or prevent hypoglycemia, hypothermia, dehydration, and give vitamin deficiencies and other problems that are before they refer the child to the hospital. The district nutrition program should ensure that adequate nutritional supplements are supplied and monitored at all our clinics by supporting the supply chain management, and clinic managers should ensure that facilities have enough supplements for children who qualified and require this intervention. Professional nurses should encourage mothers and caregivers during the EPI to bring the children for growth monitoring and promotion to ensure that there is an early and accurately detection of malnutrition or any sick children at an early age. And then this can be, again, we can include our community healthcare workers to teach them on how to identify children who are now suspected to can have a severe acute malnutrition by using mid-upper arm circumference for the community healthcare workers. I thank you.
Thank you very much, Simon. I think, like Nomaswazi Kabela says, very interesting study. I think that this has been a very useful session. We've gone a little over time. I think that Nomaswazi asks, will there be a follow-up study? Are you planning to review from 2016 the work that's been done? Clearly, the task was yours to make sure that they dealt with it.
This is a follow-up because since I'm working for the district, even the professor from the University of Stellenbosch said I must be careful because it will cut with my daily work which I'm doing. So the only follow-up to that one, my review now, it's not no longer going to be a research, but it's going to be just a work-related.
Well, you can do it as a quality improvement project, and I think
yes,
you've done a baseline. It'd be very useful to look at that. Well, let's leave it at that. Thank you all very much. I think there have been a number of people who have attended. Thank you, Simon, Sinead, and Andy, and to all who have participated. To all of you out there, I hope this webinar has been useful, and we hope that the next few will be helpful. So let's call it a day at that. Thank you once more to all the speakers. Enjoy the rest of your day. Bye-bye.
Bye.
Thanks, everyone. Bye.